We are going to finish up on our thyroid chapter today. We're going to start talking about the parathyroid glands and a little bit of the embryology and anatomy of those. So the parathyroid glands are like close to the thyroid, obviously, in their name. The superior parathyroid glands arise from the dorsal wing of the fourth pharyngeal pouch, and the inferior parathyroid glands arise from the dorsal wing of the third pharyngeal pouch. There's four parathyroid glands, which I want you to know, two superior located posterior to the mid portion of the thyroid gland, and two inferior located posterior and inferior to the lower pole. They're composed of chief cells, oxyphil cells, and adipose. They're flat and oval, and get this, they measure only 5 by 3 by 1 millimeter. So if they are normal on top of just being difficult to scan due to where they are also so small. There could be a fifth parathyroid gland, absence of glands, or ectopic glands. So the parathyroid glands, they produce parathyroid hormone. And this is the most important endocrine regulator of calcium and phosphorus concentrations in extracellular fluids. So what you're going to do is you're going to find people coming in for a parathyroid scan because their calcium levels are off. And that's when I've done them the most, is if they have blood work and their calcium is that they either have hypercalcemia or hypocalcemia. So the major target cells for this parathyroid hormone are the bone and the kidneys. It's a feedback loop, just like all the other hormones that we've learned about this semester and last semester. So PTH, it activates osteoclasts, releases calcium by the bones, augmented absorption of calcium in the GI tract, increased renal tubular reabsorption of calcium, increased conversion of vitamin D to its active form, increased urinary phosphatase excretion that lowers serum phosphate levels. So you don't need to specifically know that, just know that it's like a feedback system. So you can get like a fasting blood PTH, and that will show either hypercalcemia or hypocalcemia. A normal range is from 10 to 55 pg per ml. Elevated could cause chronic renal failure, hyperparathyroidism, or vitamin D deficiency. And decrease could be removal or destruction of the parathyroid glands. Hypoparathyroidism and metastatic bone tumors can cause the decrease there. So for a sonographic examination, this is not a gold standard exam for the simple fact that these little guys are so small and they kind of blend in with the rest of the tissue around there that it makes it very difficult. But if you do, for some reason, get a parathyroid gland ultrasound, and the prep and the protocol is going to be the same as a thyroid. So you would do a thyroid and then you would concentrate on the parathyroid glands afterwards. So where you want to concentrate when you're looking for the parathyroid glands is the posterior row medial thyroid. So posterior and medial between the gland and the longest coli muscle. So that muscle that you can see when you're doing a thyroid there. On transverse section, pay attention to the area medial of the carotid and posterior to the lateral lobe and anterior to the muscle. So that's where you need to concentrate if you're going to look. I would suggest just seeing if you can see on your cohort of classmates, because you guys probably have the best chance of seeing them on yourselves because, you know, younger and just easier scans. So the normal glands measure, like we said, very small, 5 millimeters, 5 by 3 by 1. And there's similar echogenicity to the thyroid gland, and they're very difficult to distinguish sonographically. Sometimes a longest coli or minor muscle can be distinguished for a mass. So you want to make sure that you're knowing what your muscles look like so you don't accidentally say a muscle's a mass. Primary hyperparathyroidism is a common endocrine disorder characterized by excess secretion of PTH. It's usually caused by adenoma or parathyroid hyperplasia or carcinoma, and it usually occurs in adults 40 to 60 years of age. And parathyroid adenoma is probably like the most common thing that you're going to see. It's a benign lesion. It's hypoechoic, homogeneous, solid masses. The length is about 0.8 to 1.5 centimeters. Hypervascular and possible enlarged extrathyroidal feeding artery. So this is like posterior to the thyroid gland here, and this is an adenoma. This is a new bed. Here's another image of it. So you can see on the right transverse here, it's posterior, like here's the CCA on D, and then medial to that, so closer to the midline by the trachea, you're going to see that mass. And that actually, when there is an adenoma, it makes it a lot easier to see than if there isn't. You can have hyperplasia, enlargement of all four glands, or carcinoma, which can occur in hyperparathyroidism. And that's like a younger cancer, 30 to 60 years of age. So what's going to happen? They're going to have high levels of serum calcium, slow growing lobular contour, heterogeneous internal cystic components. So a little story about the parathyroids is when I was a young sonographer, like one of my like first times, like a year in by myself, I was nervous because I was covering for a new place. And like my first exam of the day was a parathyroid ultrasound. I'm like, oh my goodness, like I have not, like, I don't even know what to do. So I have to like look it up. That this is about 10 to 12, 13, 14, 15 years ago. So it's not the same, man. We didn't have as many resources online. So I'm like looking through my books, trying to figure out what I want to do or have to do. Because kind of like if you don't do them all the time, you kind of lose it. So anyway, I get in there and I'm like going to do a thyroid and like look for the parathyroids. So he had hypercalcemia. And on top of being nervous about that, he also stated that he was a physician. So I was like sweating bullets, because I'm like, oh, I don't want to like mess up on this. So anyway, I was able to see just one of all four glands, which I guess was typically good because it doesn't mean there's hyperplasia or an adenoma or carcinoma. Um, but I would just suggest that you always are brushing up on the parathyroids just in case something like that happens. So how does parathyroid hormone act as an endocrine regulator of calcium? And it activates the release of calcium from the bones. What is the most common cause of primary hyperparathyroidism? And that is a single parathyroid adenoma. Just going to talk about the neck. You will probably, more than doing a parathyroid gland ultrasound, you will do like just a neck for a neck mass. Like doctor examines, feels something. He's like, it's not necessarily in the thyroid, but can you look at this? Because they're looking for like ducts, cysts, and enlarged lymph nodes. You can have like a sublingual glands, some mandibular glands could be swollen. So you can look through all of the neck for these kind of things. So basically when I'm doing like a neck ultrasound, what I'll do, because if it says neck ultrasound for a palpable mass, I don't do a thyroid because they don't want a thyroid. They want to look at the mass. So I'll have the patient point out where they feel like it is, and I'll just scan in that area. So, and then I'll put like area of mass, palpable mass. And a lot of the times you'll be able to see cyst or an enlarged lymph node, sometimes like an heterogeneous area like an adenoma. Um, so it's pretty easy. And sonography is good for this. You can have thyroid glossal duct cysts, which is a congenital anomaly, which we'll talk about more in OB2, or brachial cleft cysts, which are cysts within clefts or pouches on the medial neck. So this is not a picture of a cystic hygroma. This is actually a picture of fistula, but we will learn a lot about cystic hygromas in OB2 because it's one of those things that can come with a chromosomal abnormality called Turner syndrome. And basically what it is, it's a congenital modification of the cervical lymphatic system. It's going to be on the posterior neck. It's going to appear like a large mass with septations. It's thin-walled and maybe multilocular and septated. So it has lymph fluid in it. So if you work for um, like a child hospital, you might do a cystic hygroma scan. Sometimes if there's trauma or surgery, they might want to check like for a hematoma to see if it's cystic solid or mixed. Deep neck space infections, which I didn't know you could have an abscess in your neck. That's something else to worry about. Just joking. But you're like, how all this stuff can go wrong? Oh my goodness. Um, so like if like from like teeth or like an abscess from a tooth that is spread, tonsillitis, drug use, post biopsy, surgical procedures, trauma, you will probably, if you work in a hospital, do weird stuff. Like, because the doctors are just kind of trying to search to see, like, is this cystic? Is this like solid? That's mainly what is there blood flow to it? That's really what they want to know. So most are submandibular, retropharyngeal, or parapharyngeal. Sonographically, partially or fluid filled, thick walled mass, possible gas pockets, and large lymph nodes that it might be hot to touch. Patient might be sick if it's an abscess because your blood cell count is up. You can have fever, just not feel well. You'll also scan cervical lymph nodes around this time. Like in this area, they like for enlarged lymph node. Um, Lymph nodes can be enlarged for a lot of different reasons. Could be because patient's sick. Like if you have been sick before or had strep throat or, flu, COVID, whatever, you might have felt like some lymph nodes in your neck that were swollen. And that's normal as long as they go down. But if there is a lymph node that is enlarged and does not go down, they probably would want to check that out just to make sure it's not like lymphoma, metastasis, inflammation, all the stuff. So sonography is really good at looking at lymph nodes. And we can identify lymph nodes as small as 2 millimeters. And like when you guys are doing venous ultrasounds and you're looking in the groin, you should be able to catch a couple of lymph nodes in your person that you're scanning. And a lot of the times, if someone is sick or they have a thick leg or swollen leg, you'll see very enlarged lymph nodes in their leg. So it is one of those things that you're going to see a lot as you are scanning. So normal nodes are found in the submandibular, parotid, upper cervical, and posterior triangular regions. They appear hypoechoic with an echogenic chylus, oval, elongated, and elliptical. And I want you to know this, they're less than 5 millimeters, and they shouldn't have too much vascularity in them. If they're greater than 5 millimeters, and they have some vascular flow, I would definitely mention it and say possible enlarged lymph node with vascular flow, measures, blah, blah, blah. Here are some little lymph nodes. So I like how lymph nodes look. Um, they're kind of like a crescent shape with echogenic. So in A, you can see the color flow of the carotid, and I think that's probably the internal jugular. And next to it is a lymph node. That's it looks like a normal lymph node. Here's another one. Um, Pretty small one there. And another one here. So which developmental cyst results from a congenital modification of cervical lymphatic system? And that's a cystic hygroma. You'll learn that about that a lot in OB2. And which indicates the normal appearance of cervical lymph node, an echogenic hilum. So if we go back to this on A, see the hilum, the echogenic center. And that's it. All righty. Well, we made it through. So we'll see you for the next chapter.